sub of the subcommittee. Senator Monning will be joining us after he gets done with the meeting this morning, and Senator Stone will not be joining us for today's hearing. So let's go ahead and get started. Department of Public Health, please join us at the table. Oops. As folks are coming up, you, based on the agenda, you should be aware, members of the public, there are two parts to today's hearing. Part A will cover health-related issues, and Part B, we will transition and cover social services and aging issues. We plan at this point to take public comment after each agenda item, but we'll see how we go through the course of the hearing. We may consolidate depending upon topics and how we are proceeding. Welcome, Department of Public Health. Thank you for joining us. Let's go ahead and get started with the first item, which is the oral health program. Welcome.
Good morning, Senator Mitchell and members of the staff, and we have compliments to the committee for organizing.
Would you please move your mic a little closer to you? Excellent. Thank you. It's on. Okay? That's perfect. Okay. Thank you.
We want to give compliments to the committee for their write-up. The write-up does a nice job on describing the key accomplishments in the oral health program. And those accomplishments include that we've hired a research scientist. We have developed a website and completed that. Our oral health burden report is under review, and this is a foundational report for development of a state oral health plan that describes the burden of oral diseases in California, the accessibility of dental services in California, and the oral health surveillance capacity in the state. We've also been looking at other states for best practices and basic program elements which are evidence-based. The delays in the program's accomplishments to date are largely attributable to the lack of progress up to this point in hiring a dental director, as you know, and we had somebody named, and for personal reasons they withdrew, but as of this moment in time we have several viable candidates ready to go. CDPH has been working with the Department of Healthcare Services on a number of issues related to development of the program, and we've collaborated on the oral health burden report with them, featuring aspects of Medi-Cal specific objectives and Denti-Cal specific objectives with baseline data. We collaborated on the hiring processes for the dental director. Well, we're participating with developing stakeholder measures for dental. We're looking to DHCS to also participate on our advisory committee, which is in the process of planning to convene this summer. And we have collaborated on several grant opportunities for oral health related to HRSA grants. So DHCS has been a part of that process, and we expect to hear in September. So we're very hopeful that this is moving forward in a number of ways to develop a viable and robust program for the state to improve the oral health of children and adults.
Will you be kind of adjusting your timeline based on the delay in the hiring of the director?
Yes, we believe that this will be completed by the end of June. So the benchmarks from there, we should be able to achieve what's projected in the timeline from that point onward. It may just delay a month or so, the advisory committee actually convening.
Excellent. Any questions, Senator Monning?
No. Thank you, Madam Chair. So I'm looking at page 4 on the timeline. Under finalized dental state plan, it said the original date was June of this year. and the new projected date is 1 year later, 2016, 6/30/2016?
Yes, our hiring of the dental director was projected for June of
14.
2014, and now it's delayed a year. So in other words, the time schedule has been thrown off by about a year.
Yeah, but does the plan, developing the plan, wait for the hiring of that new director? Is there any work can't work be done developing that plan, or are you just going to hold it until the new director's hired?
Well, I think that there is preliminary work that's being done, and that includes the surveillance, it includes looking at the best practices from other states, it includes looking at the Deni-Cal data and the different population groups, whether it's adults or children or the use of dental sealants. So there are elements of the planning process that are already being accomplished. But actually putting together the plan will involve, the leadership piece, which is the dental director, as well as the advisory committee, which is yet to be convened. So the advisory committee is, more than 20 individuals and organizations, and it's going to be quite representative. And you'd want, DHCS, CDPH, advisory committee, and dental director all to be in agreement before you finalize a plan,
Thank you.
if that makes sense.
That's helpful. Thank you.
Can I ask a general question on kind of plans? Because I get the feeling, and I don't want to be unfairly broad, but I think this is a pretty accurate statement, that a number of the reports that the legislature is expecting are often delayed and late pretty significantly. Years significantly. I think coming up in the next presentation, Office of Health Equity, we've got a delay. And it may not apply across the board, but what's the process? I appreciate the internal process, but once you complete a plan, is there another step? Does it have to go to the administration for review before release? Can you give me a sense of 10,000-foot level understanding of the process so I have a deeper appreciation of why plans can be years late?
Jamie?
Good morning, Senator Mitchell. Jamie Matalka, Department of Finance. It's a very good question. A lot of times, the process of putting together something so big as these type of things, where you have to go through like 3 normal phases, like putting it together in an information gathering phase, and that could take months sometimes. And then you have to go through kind of going through the data, doing the data analytics, and that also could take months. And then at the end, then you got to come up with recommendations, see how that affects the budget. Then you'd have to also include finance, the administration, the governor. And if it's a collaboration with the legislature, then you bring everybody in, and from there, that's where most of the time is spent. And then once we get to that point, we try to bring it to you guys as soon as possible. But I think that a lot of the beginning work is where a lot of the time is spent. Convening everybody, making sure schedules work, and then going through that information gathering phase is part of that.
And clearly, this one was further complicated by some of it needing to wait until a hiring process, and we all know hiring within a governmental entity is complicated at best. And so I don't know if we collectively need to do a better job of, or develop a different strategy in terms of timelines, because this puts us in the position where we're doing a report's late. And I don't want to be in that position. I, as a legislator, want the report to be as accurate and comprehensive and useful to you and me as possible. So, I don't know how we do that. And it gets complicated, I think, for us if the plan has budget implications. I don't know if that then puts pressure on you to identify dates as if it's going to be done in time for the next budget consideration, when, based on past experience, you probably know it's not. So I just don't know how we have a more real, accurate conversation about these reports that you need to govern the work you do, that we need in terms of our oversight, responsibility, and expectation about kind of the flow of work. So let's
I mean, we're
talk about
definitely open to talking about.
Yeah, I don't know if we need, if it's better, instead of coming up with a date certain, if we talk about this process could take 4 months, this process could take 6 months, as opposed to this date certain that you then as departments have to come back and say, well, we've missed it and it's going to be delayed by a year. That's just, I don't think that's helpful to you. It's certainly not helpful to me, nor do I think is it helpful to the process.
Not to pile on here, but in Department of Finance, your explanation was months here, that's still less than a year. And then your third stage was internal Department of Finance administration vetting, but you didn't put a time frame on that. But it might be consistent with the chair's idea if we could break down a final target date to some increments, then we, through the process, we know, are we off schedule in that first phase? And how are we going to adjust? And then when the adjustment is a full year, that seems
Excessive.
excessive. And again, understanding the delay with the director, I know one was in place and then due to personal reasons, as you mentioned, that was obviously a setback, not foreseeable. But yeah, a full year seems excessive, but thank you.
And I think as we continue to have the conversation about different budget building methodologies, whether it's zero-based budgeting or whatever, plans and timelines are a critical component of that. And again, from my perspective, this is the area where we have a partnership role, where as a legislator, I want to look at the plan to figure out how we can be of service to help you be successful with the plan. If it's additional resources, if it's a redirection of priorities, that's how I review the plans as a policymaker, as a budget subcommittee chair. And so having them timely and relevant, I think helps you, helps me, helps the whole process. So I think this doesn't just apply to Department of Public Health. Like I said, a number of the plans that we've reviewed in the subcommittee are late. So I just think it's a broader conversation. I hope that all the departments would consider recognizing the true value and use of the plan to you and your planning and to our oversight responsibilities. Any other questions? Finance or LAO, any comments on the oral health presentation? Public comment, oral health.
Good morning, Chair and members. I'm Brianna Pittman with the California Dental Association. In last year's budget, CDA supported the proposal to bring on a dental director to oversee the oral health program, and we are in fact pleased with the search process. I know it's been a little delayed, but we really appreciate the work that the department has done, and we look forward to the dental director coming on board and to working with them, along with other stakeholders on a comprehensive state oral health plan.
Thank you. I had the opportunity to sit down and meet with the oral health director for the state of New York and see a presentation, and was just really impressed with what they've been able to accomplish from a public health perspective in a relatively short period of time by having the leadership and the direction of a person in that position. So I too am looking forward to you being able to secure the right person for the right position so we can look at some improvements across the board in California. Thank you.
We hope to be able to give you an update on that very soon, Senator.
I appreciate that. Thank you. Moving on to number 2, Office of Health Equity. Good morning.
Mitchell, Senator Monning, happy to be here this morning to provide updates specifically on our California Reducing Disparities Project, our Racial and Ethnic Disparities Coalition, as well as our statewide plan for health, achieving health equity, and then lastly, on our Health in All Policies Task Force. So I'll start with our California Reducing Disparities Project, which has 2 phases, Phase 1 and Phase 2. And Phase 1 primarily consisted of assembling strategic planning work groups. And kind of to actually step back a bit further, this California Reducing Disparities Project was set up to address multicultural mental health disparities, particularly across 5 cohorts of high priority vulnerable communities, particularly the African American community, Latino, Native American, Asian Pacific Islander, and the LGBTQ. And the intent of this particular project is to address prevention and early intervention projects on the local level that don't typically fall within the conventional sense of prevention and early intervention, and when we think about mental health, and also to address stigma and discrimination in those communities. So a few years back, when this project started at the Department of Mental Health, 5 strategic planning work groups were assembled, and based on community-based research and interviews and surveys, each of these respective cohorts came back and produced population-specific reports providing an extensive history around the disconnect and in the institutional challenges of these communities getting adequate mental health services. And included in those population reports were recommendations, and many of those recommendations have been taken into consideration and consolidated into this Phase 1 strategic plan. And I'll be referring later to another strategic plan, but for the sake of this update, this strategic plan is relative to the CRDP project, the California Reducing Disparities Project. In collaboration with our partner and technical writer of that strategic plan, which is California Pan-Ethnic Health Network, we put out this strategic plan for public comment on February 17th. That public comment period concluded. It was 35 days for the public to provide input on this strategic plan before we finalize it. In response to that public comment period, we got over 700 recommendations and feedback from communities across the state of California to take into consideration kind of categorical themes and other essential objective content that should be integrated into that strategic plan so that we can finalize that. CPAN, or California Pan-Ethnic Health Network, has taken that information into consideration in partnership with the Office of Health Equity, and as we speak, that strategic plan as a part of Phase 1 is being finalized, which is critical as I transition into the update on Phase 2 for the California Reducing Disparities Project, which is the greatest opportunity here, and that's $60 million that comes from the Mental Health Services Act fund that targets this multicultural mental health program and allows us to invest in opportunities to evaluate and validate community-defined evidence practices. So the benefit of that is many mental health departments at a county level have not traditionally engaged the diverse communities in a consistent and a substantive way as far as addressing their mental health needs in a culturally congruent way. And the intent of this project is to demonstrate that non-mainstream but yet effective community-defined practices, whether it's community gardens, faith-based interventions, or a wide array of other practices identifies, to demonstrate that they work. So evaluation is a significant component of us investing these $60 million over the next 5 years. And the $60 million will be allocated and spread across 5 various solicitations as a part of Phase 2. And we're looking to start issuing the RFPs, or the solicitations, in May. And to just get into some detail as to what each of these solicitations consist of, one of the solicitations will be to engage a statewide evaluator, and that statewide evaluator contract will be spread across a 5-year period or 60 months. We also were looking to issue contracts for 5 technical assistance providers to assist each of those 5 cohorts of groups that we're going to be working with over a 54-month period. We're looking also to contract for 15 capacity building pilot projects. That's an important part of our kind of the values piece of the CRDP project, in that we want to do business differently. There are many community-based organizations that have provided very effective, culturally congruent practices and interventions. However, they've been kind of blocked out from the institutional opportunities to get contracts, and they're not able to check off certain boxes, if you will. So we're working closely with those communities through, we look forward to working closely with them on engaging through capacity building pilot projects. We will also engage in 20 implementation projects. That's the traditional sense of demonstration projects that we'll be investing in. And then lastly, we're actively creating education, outreach, and awareness solicitation drafts. So with those 5 categories of solicitations, we just concluded a period of public comment one thing that we did differently with respect to issuing contracts is we put out the drafts of the contracts or the solicitations, the RFPs, for communities to get input. And from 60 different sources, we got over 200 comments. And the intent, once again, is from beginning to end, we want to engage key stakeholders in a meaningful way. So as a part of that process, it concluded April 8th, and we look forward to sometime in May issuing our first set of RFPs so we can start to get feedback and bids from communities across the state. And we believe that evaluating this project over an extended period of time will show that kind of the unconventional practices that are out there in our communities to address mental health and the stigma and discrimination associated with it, that they work. But that evaluation piece has often lacked, especially when we're able to get money out, but yet on the back end, we don't really provide that objective criteria to show that these efforts work. Another piece of the California Reducing Project that is continued is our partnership with the Mental Health Association of California. That's tasked with staffing our Racial and Ethnic Disparities Coalition. This is an ongoing kind of partnering coalition for our CRDP project that allows us to engage a diverse array of stakeholders across the state, and not necessarily all of the members of this coalition belong to those 5 groups. So it's a richly diverse group, and we're continuing to have conversation with them to identify what are the future opportunities to engage the needs of those that aren't necessarily in that 5, the big 5 initially in this project. And REMCO, as a subsidiary of the Mental Health Association of California, has been a great partner in assembling this coalition. We've gotten a lot of feedback, a lot of support, and as far as the strategic plan and the solicitation phase for the California Reducing Disparities Project, this coalition and other stakeholders have been very supportive every step of the way. Within the mandate that creates the Office of Health Equity, we are charged with creating a demographic analysis as well as a health equity statewide strategic plan. As the Deputy Director, I decided that we would integrate these 2 legislatively mandated deliverables. And part 1 of this statewide plan, which we're calling the California Statewide Plan to Promote Health and Mental Health Equity, part 1 is the demographic analysis, or in the traditional sense, a disparities report, that across social determinants of health, we're demonstrating where a lot of disparities and inequities exist, not only by racial or ethnic groups, but we're being very true to all of the vulnerable communities when we think about applying the gender lens and breaking out data by women and men, boys and girls, educational attainment levels, income level, to give people a sense of where these disparities and inequities exist. So based on that phase 1 objective criteria, or the demographic analysis, that justifies the second part of the statewide plan, which is the actual strategic plan to achieve health equity. We work closely with our 25-member external advisory committee in collaboration as required by the mandate, but I also think that organic approach allowed us to arrive at a draft of a strategic plan that really makes sense. And we also worked with our Health and All Policies Task Force. So it's a cross-sectoral approach to achieving health equity that isn't solely predicated on just what state government will do, but yet will be a critical driver in that. I saw the latest draft of that strategic plan where we're updating some data points. The target date for that was July 1, 2014, and obviously that date has passed, but we are looking to conclude this report and make it public through dissemination within the next month to 2 months, no more than that. But the information we've been able to integrate by virtue of not particularly meeting that deadline is actually a really, really good thing, especially when we think about the opportunities we've had to add more substantive information with respect to the gender lens component around women and girls' health, and also from boys and men of color perspective. And then lastly, I have an update on our Health and All Policies Task Force and our team out of the Office of Health Equity that has staffed that task force, which now consists of 22 members. And over the last 12 to 18 months, the task force has been extremely busy. And as just a reminder of who sits and represents on this task force, we have Cal EPA, Food and Agriculture, Department of Education. Many of these, what you would say, non-traditional health entities, but are health partners. When the policies and decisions that they make downstream very much so have implications on our health. And they've been absolutely phenomenal partners as we've tackled the Caltrans approach to their active transportation program grants. We partnered with them on that. Affordable housing and sustainability grants, regional transportation guidelines, general plan guidelines, as well as the governor's environmental goals and policy report. As far as our future direction, kind of the next frontier for the Health and All Policies Task Force, we look forward to tackling access to healthy food, community greening, and also creating learning opportunities within state government to teach the workforce about how we integrate the health and all policies lens in a practical way to all the work that we do. But the leading priority as far as the next frontier for Health and All Policies Task Force is community safety through violence and prevention. It's really a cross-cutting topic that we're going to tackle in months and years to come, and that it uniquely is a priority and has implications in each of the departments, agencies, and offices that are members of the task force. Lastly, from a staffing perspective, staffing accounts for the bulk of the costs that we execute and use out of the Office of Health Equity to staff the Health and All Policies Task Force. To break down the staffing component of that, the Office of Health Equity, we have one health program specialist that's funded from our Federal Prevention Health and Health Services Block Grant. And the 3.5 other FTEs that we have are staffed through the Public Health Institute. Has been a great partner in advancing our health and all policies work. And the staff that they have are funded out of a grant, or grants provided from the California Endowment, Kaiser Permanente, and we collaboratively with the Public Health Institute are working with those same entities as well as other private foundations to, in hopes of renewing funding for some of these that may expire at the end of this year. So health and all policies remains a priority for us. When we think about violence prevention and some of these other key issues, it's imperative that we continue to work this collective impact approach around engaging other partners when we think about the social determinants of health on how we achieve health equity. So it's been a busy, very productive year. I've been in this role for about 18 to 19 months, and we really appreciate the support of our partners within the California Department of Public Health, our partners at agency level, as well as our partners within the Department of Finance. Every step of the way, we work collaboratively to ensure that when we produce our deliverables and we think about these plans, that they're solid, and they have the best representation that we can when we think about this rich group of vulnerable populations that we're challenged to represent. So even with some of the delays, it's allowed us to kind of factor in some new information that we may not have been able to consider initially, and I'm grateful for that opportunity. So that concludes my update.
Finance or LAO? Senator Monning?
Thank you, Madam Chair. Thank you, Mr. Miller. It was a very comprehensive report. You guys have obviously been busy. We heard some testimony yesterday in a health committee hearing from Cambodian immigrants.
Yes.
And some of the unique challenges, mental health challenges faced by that community. So when you talk about the kind of broad categories, including API,
Yes.
Could you just share a little bit of how do you break down within the API community so that, for this example of the Cambodian immigrants, how do you make sure maybe previously unrepresented or underrepresented groups within that broad umbrella are reached through the work that you're doing?
Yes, I really appreciate that question. A few months ago, we provided technical assistance, I believe, to Senator Laura's office and some staff that had an inquiry about that. And this opportunity has come up in two ways. One, primarily in the data, how we produce data, and how there is not really a standardized approach across various public data sources to reporting out on Asian Pacific Islander groups. But then you have some that disaggregates the data to show that there are significant differences in various health and/or mental health outcomes, or even life expectancy when we look at Japanese, Chinese, Hmong, Vietnamese, Cambodian, and other groups. But that consistency is not necessarily there. So it makes it challenging for us in some indicators to report out. But then there are other indicators that we do the best we can to disaggregate that information, to objectively see where the opportunities are in the data. And what makes it very helpful is when we're able to drill down through some of our data assets at census tract levels across the state to see where some of these communities are uniquely positioned, whether, we look at climate and health or educational attainment levels. We're able to use that objective information to drive our priorities. From a mental health perspective, our Asian Pacific Islander Strategic Planning Work Group did an awesome job in the population report in breaking out some of the internal cultural opportunity areas there are associated with stigma and discrimination around mental health, whether it's from patient families to the provider not disclosing, critical information from a cultural sensitivity perspective, and then, but also showing how these communities have demonstrated resilience in bringing culturally effective efforts to prevent and intervene from their country of origin, and how we need to be more open and receptive to integrating that into, or at least adding it to the options from a prevention and early intervention, adding it to that group of what we consider to be recognized and even to some extent even reimbursed. So we've been engaged particularly with the Cambodian community. We're hopeful that as time progresses, we can have more standardized approaches to drilling down to identify what's really going on. And right now, to some extent, it's fragmented.
Thank you. It's helpful, and I'm also glad to hear of the strong partnership with REMCO and CPEN, obviously, that along with the governmental entities.
Yes.
So thank you. Thank you, Madam Chair.
Thank you.